Dear colleagues, welcome to another episode of the Synapse e-learning series. With us today we have Mr. Joseph De Bono, a general surgeon with a special interest in surgical oncology, with whom we shall be discussing the role of radioisotopes specifically in breast surgery. Mr. De Bono, thank you very much for accepting our invitation to do this session. Mr. De Bono, radioisotopes is probably a subject many of our audience are not very familiar with. Can you kindly explain radioisotopes, in which situations it is used, and why it is relevant to all of us healthcare professionals, even those who are not oncological surgeons, as is me and most of our audience?
So radioisotopes are chemicals which produce radioactivity, and these can be picked up by various machines, Geiger counters, special X-ray machines. So you can actually see where this radioisotope is being pulled. This radioisotope is usually attached to a chemical which is present naturally in the body, and depends on where this natural goes, then you can actually see what is happening in the body. So radioisotope is used in a number of situations where you are following the way a chemical works in the body. So for example, it is used in diagnosis. Most of us are familiar with the PET scan, where the radioisotope is attached to glucose. Glucose is used by tumor, so where there is tumor, the radioisotope will collect. It is also used in specific tumors such as the thyroid, where you attach the radioisotope to iodine, which is absorbed by the thyroid gland, and where the iodine is used most, the radioisotope collects. It is also used in the heart, where cardiac function is being assessed to see which parts of the muscles are using the glucose, again, like in PET scan. And the parts which are working properly will use more glucose, so they will show up more. So that is from the diagnostic point of view. Then there are the therapeutic radioisotopes. The therapeutic radioisotopes, in this case, the dose of radioactivity is very high. And where in other cancers we use radiotherapy from externally, so you are shooting radioactive waves against an area. So you cannot select the tumor cells. What you're doing this time is using radioactivity in a high dose, attaching it to a chemical which is absorbed by the tumor, and this radioactivity then goes directly to where you need it most. So it can go to, for example, in the thyroid, when you're treating thyroid cancer, you use radioactive iodine. You can also use it in pellets, which are implanted in certain areas of the body to treat radiotherapy locally, to give radiotherapy locally, for example, in the prostate and in the cervix. You can implant pellets with radioisotope to give radiotherapy locally. But in breast, it is used to help in the localization, to identify where a lesion is. So what happens is that we use the radioisotope. It is injected into the areas where we need to find a lesion, and using a handheld probe, we can pick up where the lesion is exactly.
Thank you very much for that overview. So we concluded, or we went through the use of radioisotopes as treatments and in diagnosis. Does it have a role in staging and determining lymph node involvement? Although it is not used to actually stage, it is used in the breast especially, and in other areas where you need to know the lymph node staging, to try to identify which are the nodes which drain the area of concern. So for example, the two most important tumors we're talking about are the breast cancers and melanoma, skin cancers. So when you're treating for breast and for melanomas, you have to identify which are the nodes which you need to remove to see where the tumor is going to check if these nodes are involved with tumor. And the best way to identify which are the best nodes to remove without removing extra nodes is by giving the radioisotope, injecting the radioisotope in the area where there's the tumor. This moves along the lymphatics, goes to the lymph nodes, which are first draining the area of the cancer, and you can actually select those to be removed rather than remove the whole nodes. So this will lead to less complications and less side effects from the surgery.
Focusing more on the treatment and surgery of breast cancer, what is the current protocol for the use of radioisotope scanning in breast surgery?
So there are two situations where we use radioisotopes in breast surgery as a localization tool. The first one is what we call radioisotope occult lesion localization. So with the advent of screening in breast, we are identifying tumors which are not palpable. You can't feel them before the surgery. So to know exactly where we need to remove without removing too much breast tissue unnecessarily, we are using radioisotope localization. So what this means is that the radiographer or radiologist before the surgery injects the radioisotope into the area where the tumor is exactly. So when we go in for surgery with a handheld Geiger counter, we can find where this isotope has pooled, and we can remove just that area. Before, what we used to do is use wires. Now, wires, the disadvantage of wires is that they can only be put in using X-ray as well, like ultrasound. But the problem with the wire is that if the breast is very firm, the wire can bounce off, so it doesn't go into the right place. And if the breast is very soft, it's very fatty, the wire can move by the time the patient comes from X-ray. Radioisotope doesn't move, it stays where it's put. The radioisotope we use is technetium labeled, so it's a heavy technetium, and it is attached to albumin. Albumin is a protein which is present in the body or everywhere. But the albumin we use in occult lesion localization is heavy albumin, is macroalbumin, so large molecules of albumin, so it cannot move from where it is. The body doesn't absorb it immediately. It takes quite a few days before it's moved. It moves from the area where it's injected. So you don't even need to do it on the day, you can do it the day before. And when you remove the area, you're actually removing the radioactivity with the specimen, so it doesn't stay in the patient. The second role of localization, the second role where you use localization is what we mentioned already slightly before, is for identifying the nodes, what we call the sentinel nodes. Sentinel nodes are the first nodes which drain the tumor, and because they are the first nodes which drain the tumor, they're the ones that are most likely to have metastasis if the tumor is spreading. So what happens is radioisotope is injected in the breast, this time with a nanoalbumin molecule, so a small molecule of albumin which can move, so that it will be taken up by the macrophages and taken to the lymph nodes. So within 1-2 hours, it would have reached the lymph nodes, and then it stays in the lymph nodes. Now, then with the Geiger counter, you go and identify which are the lymph nodes which have taken up the radioisotope, and you can remove just those. To help us also in identifying which lymph nodes are the ones which have taken up the radioisotope, we also inject a blue dye with the radioisotope. You can also see a color change in the tissue, so you can even it's easier to find these lymph nodes without doing a lot of dissection and a lot of possible complications like damage to the nerves or damage to lymphatics. And you also can take an X-ray before a lymphangioscintigram, what is called a lymphangioscintigram, and the site of the lymph node can be marked on the skin before, so you can actually make a small incision rather than a big incision to find where the node is. So these are the two main reasons where we use localization in breast, with its advantages, obviously because you are limiting the amount of tissue removed, so there are less complications, and you are sure you are in the right place where you want to be to remove what is worrying you.
Use of radioisotope scanning in breast surgery as in breast surgery, as you explained, definitely has a lot of advantages, as you very well explained. Are there any possible complications with the use of radioisotope scanning for our patients?
The worry of radioactivity causing harm in these patients is very low. In fact, we use it even in pregnant women who need surgery for breast cancer. First of all, it is localized. It is used just in the area of need. And also, the dose is so small that it is far less than what we are exposed to in our daily life. So, yes, you still are using radiation, but it is not going to affect neither the patient nor the people around them. And actually, after the surgery, what happens, because we're removing the area where we have injected the radioisotope, so you're removing the radioactivity as well, because part of the operation, you're removing the radioactivity. So there are no complications regarding the dose of radiation. One of the main problems, which is rare, is that the radioisotope, especially in the sentinel node, doesn't move to the nodes. So it might have been done for nothing, but what we do in that case is we use the blue dye, as I mentioned. Mm-hmm. So that gives a second sort of line of identifying the nodes. And if still you can't find any nodes which have picked up the tumor, then which have picked up the radioisotope, then you remove what we used to do before, the axillary clearance.
Are there any precautions or things that patients undergoing scanning using radioisotopes have to be careful of after having the procedure?
Unlike what you do in PET scan or in iodine scanning, in breast surgery you don't need to, because as I said, the radioisotope is removed during the surgery itself. So there's nothing left to worry the patient.
Mr. De Bono, thank you very much for a very, very good overview of the use of radioisotope scanning, which has definitely increased our knowledge, especially for us healthcare professionals who are not in the field of oncology. What is a final message, a take-home message for us healthcare professionals? What should we, healthcare professionals who meet patients requiring the use of isotopes, tell our patients about the procedure, so that as healthcare professionals pass on a common united message to our patients?
So basically what we must stress in telling our patients is that these are very safe. They don't cause any problems. They don't cause any complications. They are there to help you, to help the surgeon minimize the amount of surgery that needs to be done unnecessarily, and also give the best treatment for the patient with the least possible complications. So familiarity with what's being done is very important for our healthcare professionals, because I am sure that even although we explain in the clinic what is happening for the surgery, during the surgery, most people will, because they've just been told they've had cancer, would probably blank out. So then they would need reinforcing of what they learned, what they heard during the clinic from their GP or from family doctors or from other healthcare professionals who are looking after them during the process. And being aware of this radioisotope localization is very crucial for the GPs and for the healthcare professions looking after these patients.
Dear colleagues, I hope that through this overview we have helped you to further understand and familiarize yourself with the use and role of radioisotopes in breast surgery. I invite you to complete this educational experience by completing the set of multiple choice questions that are associated with this session. Following this, you can download the certificate of participation from the Synapse e-learning site. For more e-learning experiences, I invite you to visit www.thesynapse.net/CME.